So thank you very much. I'm very happy to be here today to talk to you about the presentation I gave for the World Health Summit this week in Berlin, Germany. The title of my talk was called Urban Adolescents' Perceptions of Health Worldwide, Qualitative Findings from the WAVE Study. And this was a study that's been funded by AstraZeneca. And it's a study with the overall theme to look at how can we connect vulnerable adolescents to health. So WAVE actually stands for the well-being of adolescents in vulnerable environments. So in order for us to really tackle this question, we wanted to really break it down. And so this first phase included a number of different methodologies, qualitative methodologies, to look at how we can define adolescent health in a number of different global sites. So for this presentation, I'm just going to first of all talk about the aims and the methodology of the WAVE study, and then focus on three primary findings, which is really to describe the health of adolescents, to discuss the perceptions of adolescents about the factors that were related to health, and then look at how the interaction of these factors determined how and when adolescents sought help in healthcare. And then finally, I'm going to place them within the broader literature around this, and then suggest some implications and conclusions. So for this first part of our WAVE study, we really wanted to, first of all, describe the health of adolescents, primarily aged 15 to 19 years, in 6 urban communities. And you can see these 6 urban communities are listed on this slide here. But within each of these areas, there was a specific geographic area that was targeted. There are some asterisks that I want to point out. So in Ibadan, Nigeria, for this analysis, we have only 3/4 of the data. They are still coding on some of the other methods. And then for Rio de Janeiro, they are actually still in the field. So the data from that site is actually not included into this analysis. I also want to point out that in Shanghai, our partners there really only focused on adolescents who were migrants, and that is a growing population in that city. So in addition to describing the health, we also wanted to explore the factors that they perceived were influencing their health and their access to help. And then we also wanted to compare these findings across sites. So again, our target population were adolescents ages 15 to 19 in these urban neighborhoods. And each of these neighborhoods were very economically distressed. And we focused on adolescents who were in school and out of school, and then those adolescents who lived in households and those that were unstably housed. They could be living in shelters or in special other types of orphanage communities, such as in Johannesburg, there was a number of shelters and orphanages there for kids who had lost their parents to AIDS. In each of these sites, our data collection efforts actually occurred on 2 levels. So the first really included gathering data about adolescents. And for this, in each of the sites, we had our partners and our researchers do a walking and mapping of the area. And within this, we listed all of those places where adolescents could be found hanging out, the parks, and then those types of organizations that could be serving youth in the community. And from that, we did a listing of all of those types of organizations, which included church-based and community-based organizations. And from that, we selected 20 key informant interviews with these adults and providers of youth-serving organizations. After that, we then collected data with the adolescents, and there were a number of methods that were used for this phase. The first included a photo voice among 10 youth, and they were divided by male and female. And basically what we did is we gave each of these 10 youth cameras, and we had a professional photographer train them to take pictures of what health meant to them in their communities. We also did a community mapping and focus groups among youth in 8 different groups, and this was really to have them draw what they felt their communities looked like, and then to map out the areas where they could hang out with youth and where they could access resources. And then finally, we did 20 in-depth interviews with youth, a lot about to gain their personal perspectives and experiences about what it was to be an adolescent in the community and what they felt were their primary health concerns and where they could go for help. So in the sites that we got the data, which included Baltimore, Shanghai, Johannesburg, Delhi, and most of Ibadan, all the interviews that were conducted were recorded, they were transcribed, and they were translated. And then these transcripts were then imported into Atlas TI, which is a qualitative computer software that is commonly used. And then each site then was responsible for coding the transcripts. And to help them do this, we worked with each of the qualitative researchers in the sites, and we developed an initial code list that represented what we thought were the major themes coming from the data collection instruments and from our data. This was then shared among each of the sites, and they then provided us feedback, and a finalized core code list was then distributed to all the sites. After each site was then finished coding their transcripts, these then files, which we called hermeneutic units, were sent to us, where they were all uploaded, and then our team then created matrices of these codes for us to be able to compare the themes across the different sites. So what did we find? Well, again, our first question that we wanted to look at was, what did they think were the top health concerns among adolescents in these very distressed communities? And amazingly, across sites, there was a general agreement that the big health concerns were really along gender lines. So, for example, among adolescent girls, sexual and reproductive health problems were very prominent. However, among boys, tobacco, drugs, and alcohol consumption was actually very common, and in most of these sites, this further led to violence. I do want to point out, though, in Shanghai, smoking was actually the most prominent health problem among boys, whereas in the other sites, drugs and alcohol were the most prevalent. And just to share with you some of the quotes from our data about these top health concerns. First of all, we have a female adolescent from Baltimore saying, "Oh my gosh, at my school, half the girls in my school are pregnant, or already have a baby, or about to have another one. Everybody is pregnant." From a female adolescent in Shanghai, we see a lot of the girls suffer from gynecology-related health problems. In fact, my menstruation is not normal. Now, a lot of women have uterine fibroids, and people will die of this disease. Looking at the voices of males about drugs and violence, we see, for example, from Johannesburg, a male adolescent saying, "You see alcohol everywhere. When you go by the corner, there's a tavern. When you turn, there's a tavern. When you turn around, there's someone selling drugs. Daga is what they call marijuana, and you would think that they are selling sweets or samba chips." From a key informant in New Delhi, he states, "Here young people consume too much intoxicants. There's one child about 8 to 9 years old, and he smokes cigarettes and eats gutka, which is a type of smoking tobacco, because he stays with the big youngsters, and his parents don't pay any attention to him. Here there are many children of that kind here." And although it wasn't a top health concern per se, it was interesting to note how large of a problem the lack of safety was in the lives of these adolescents, particularly those coming from Baltimore, Johannesburg, and Delhi. And in Baltimore and Johannesburg, many, especially of the girls, didn't even feel safe in their homes. And here's just a snapshot of an exchange between an interviewer and a female adolescent living in Hillbrow, which was one of the communities in Johannesburg. "What would you say would be your most pressing health problems?" "I think in Hillbrow, because I don't feel safe anymore." "What makes you not feel safe?" "The thing is that where we stay, you will hear a person screaming from being beaten up in the middle of the night, and there are also break-ins." And this was a very common theme that was seen over and over again, particularly in Baltimore and Johannesburg. So in addition to the top health concerns, the other thing that we wanted to know is, what did they think were the factors that were perceived to be linked to their health? And again, another surprise was that the physical environment was one of the most dominant themes in all of the sites. And here's just some examples of some of the quotes that we see in this. So from Baltimore, a male adolescent says, "All these neighborhoods, all these alleys, some of all these big rats going around in people's trash. It's nasty. Then there's these vacant houses, and you've got houses that are right next to these vacant homes. And so what is the health department doing? Nothing. And then there's people staying in these vacant houses, and then you've got drug needles on the ground." Similarly, from Delhi, "It's not safe for us to stay here. There's so much dirt, and the smell keeps coming from everywhere. There's dirty water found lying on the roads, and the dirt is spread everywhere." From Shanghai, "The sanitation is not good. People litter on the streets. Some children defecate on the playground, And some people litter there, even though there's a trash can nearby. And finally, from Ibadan, the environment is not conducive because it smells of urine and it is littered with papers and other refuse. And here are just some photos of from the photo voice methods that youth took. And you can see here just how much trash and garbage was portrayed in all of these pictures, and how youth were just simply not satisfied with this living condition. And here's an example from Ibadan of a borehole, and just how they knew that water, this contaminated water, was going to spread disease. And another picture of garbage from Ibadan. And this was like this across all sites. And it was something that we weren't expecting, because we didn't realize that youth were just fed up with this. They did not approve of these living conditions. What other factors were perceived to be linked to health? Well, the other most dominant factor was the social environment. But unlike the physical environment, this actually varied across sites in terms of how it was perceived to impact adolescent health. So in Baltimore and Johannesburg, the social environment was actually really limited. And it was characterized by adolescents growing up essentially without parents. In Baltimore, it was primarily related to adolescents having parents who were in prison or on drugs, whereas in Johannesburg, the primary health problem was AIDS, and this was causing a lot of adolescents to lose their parents. In Shanghai, it really depended on the type of migrant that the adolescent belonged to, and in Delhi and Ibadan, it really depended on gender. So to look at this more closely, here we see in Baltimore and Johannesburg, again, it was very common for adolescents to live without one or more parents. And this essentially resulted in many adolescents in these communities essentially being raised by themselves. And here's an example of an adolescent female from Baltimore talking about this. A lot of the parents is out here on drugs. So for the kids are being raised by themselves. Foster kid system is worse because they, the foster parents, are just in it for the money. They don't help. And the social workers, they just give up on the kids because the kids don't care. They have nothing to live for. That's because the parents had ruined their lives and their parents' parents ruined their lives. So it's a big cycle going on. And it's like, who are we to blame? Similarly, a boy in Johannesburg states, I do everything on my own. Even at home, I'm on my own. So I wouldn't say I need help because I'm used to doing everything on my own. In Shanghai, however, it really depended again on what migrant group the adolescent belonged to, and key informants described this in terms of three basic classes. So the first class were migrants who owned businesses, and they were the entrepreneurs. They were very engaged with the education and welfare of their children. So for adolescents in this class, they were very well cared for. They had a wide social environment. In the second phase, it was a little bit more varied, and this included both migrants who were employees of business, some of whom had more education and were able to own houses, and it also included the normal wage earner who often rented homes. And again, adolescents had depending on which class they belonged to, they had very different degrees of who they could turn to help and how big their social networks were. The last phase, however, the street vendors, the key informant stated that the parents of these kids were the least concerned with their kids, and they were thought to have the lowest degree of social environments around them, or the lowest degree of the social network around them. And it was primarily related because the street vendor children were more likely to stay in poor communities, were more likely to be undocumented, and most vulnerable, and consequently were the most likely to be discriminated against by the local Shanghainese. And here's just an example of a quote from a key informant talking about this. The Shanghainese parents are the most different from these migrants. They watch their children relatively tighter. Because of the bad conditions of the migrant population, the parents leave home very early for work, and many of the migrant children end up doing all of the household chores by themselves. So they're essentially, again, like the kids in Baltimore and Johannesburg, being raised by themselves. In Delhi and Ibadan, though, it was interesting that the social environment was really related to whether one was male or female. Because females in both of these sites were very restricted from going outside their homes, and as a consequence, their social network was much more limited. Males, on the other hand, in both of these sites were given full freedom to go out, meet their friends, typically in cyber cafes. and they knew exactly where to turn to for help. In Delhi, the reason why the females were restricted was often thought to be because the parents were preserving them for marriage. And here's an example from two key informants talking about this. So the boys get full freedom and they can go anywhere. They can roam and do anything they desire. But the girls can't be given this full freedom because if anything were to happen to them, it would defame the family. Parents believe that the girls are someone else's, and it's important to get them ready for marriage. So that's why they wanted to keep them in the house to prevent them from having any negative interactions that would defame their family. In Ibadan, however, the girls were just perceived to be generally weaker and more vulnerable because they were often victims of sexual harassment among boys if they were found walking outside at night, especially. And here's just two males, adolescents from this community, talking about this. What we, the males, are facing is different from what the females are facing, because if we are not happy, we can go and play ball or table tennis to wipe away the sorrow. But they, the females, don't have this opportunity. To be a boy in Yemetu, which was the community in Ibadan, a boy can go anywhere they would like at Yemetu, but girls have some particular places they must not go. So girls are not really free at Yemetu because of the guys. So lastly, we wanted to know, how do these environments, the social and the physical environment, interact to determine how and when adolescents may seek help for any of the problems, health problems or non-health problems that they face? And what we found interesting is that adolescents who were in the most vulnerable places, such as in Baltimore, Johannesburg, the lower class migrants of Shanghai, and the girls in both Delhi and Ibadan, were the least likely to even know about sources of help and support. But it's important to point out, though, that across all sites, physical health was just not a top concern. And consequently, seeking services or help for a physical health problem was just not very common. And there may be a possible reason for this. And one key informant from Baltimore said this well. And as you see, it's really related to the limited social environment that they have. So as an example, here is the key informant from Baltimore. I don't think the youth, know what healthy looks like because they're not nurtured at home. They have no self-esteem and they will not speak up for themselves. So their whole psyche is whacked. Getting help is shameful. They want to hide it. So how do we make sense of these findings within the broader literature? Again, I want to point out that we were not at all set up to look at the relationships between the physical and social environment, but this is what emerged from the data. And so in trying to place this within the adolescent health literature, there was very limited research that's been conducted to look at how these environments interact to influence adolescent health. So as a consequence, we broadened our literature base to look at particularly literature that's been published in the psychology and broader health environment research. And what we found was that there is a number of research studies that have looked at, particularly among adults, but looking at the association between the physical and social environments with regards to mental health. So, for example, there's been studies that have shown that the poor neighborhood resources, the busy traffic, and hazardous exposure have all been reported to have positive associations with stress. Likewise, components of the social environment was also important. So the lack of safety, which we saw in our findings, the residential instability, which was also noted, and the low SES was all related to stress. Moving beyond just the mental health linkages, there's also been studies that have found that in neighborhoods where residents feel safe and they have a sense of shared values, they actually make use of the local facilities and resources which contribute to maintaining their health. However, having a fear of safety, like we saw in our research, really created a social environment which undermined both mental and physical health. So to look at these relationships on a conceptual framework, I found a framework that Matthews and Yang in 2010 had developed. And this really maps quite well on the findings from our study. And here you can see that on an individual level, which is the straight circle, and the neighborhood level, which is the dotted circle, shows that for example, on the individual level, stress has a direct relationship with health. And beyond the individual level, this conceptual framework shows that both the built environment, which is essentially those things in the physical environment that are man-made, and the social environment are also related to the variations in individual health across neighborhoods. And then beyond at the neighborhood level, we can see here that the built environment and the social environment is also thought to be indirectly related to stress and health. And so this conceptual framework really fit nicely with trying to explain the relationships that we saw in our study. So again, the WAVE study, this first phase of findings, really shows the need to examine these linkages much more in depth. And so what we are planning to do is a next phase, a survey phase, that hopefully will look at some of these questions. And again, from our study, in some ways we have more questions than answers. And so some of the research questions that we'd like to examine further are, do adolescents who perceive a poor physical environment also have a higher sense of fear? And how does the social support moderate that relationship? And finally, how do these relationships influence the health behaviors and outcomes of adolescents? Again, we're going to be doing a next phase very soon where we're going to be using respondent-driven sampling among 400 adolescents in each of these phases, in each of these neighborhoods. And we'll be collecting baseline data about health, resources, and factors thought to affect the health concerns, as I brought up earlier. We want to test the generalizability of the findings from the qualitative study, and hopefully both this phase and the earlier phase will be able to help us to prepare future health promotion interventions in each of these settings. So I think the implications of this research is really important. And first, on a global level, we often compare the health of adolescents by the income levels of the countries. We compare adolescents in high income levels and middle income levels and low income levels. But really what this research shows is that adolescents in poor communities, irrespective of the income level of the country, share more similarities than differences. And this really begs the need for more research on the role of the physical environment and the social environment together in influencing adolescent health globally. And the findings of this research may suggest that economic development initiatives may also help improve the health and well-being of adolescents. And this has not been done on an at all an extensive scale. There has been a few studies done in the US where they have actually given vouchers to families who live in high poverty neighborhoods to move to low poverty neighborhoods. And what they found was that a number of adolescent health outcomes, particularly among girls, really did improve after moving to a low poverty area. And it was really related to their sense of safety getting improved. So I thought that was very interesting, and it was a way for us to really think more clearly about how these relationships are influencing adolescents in these poor urban areas. So I'd like to thank all of my collaborators on this study, which include the Shanghai Institute of Planned Parenthood. In Brazil, I'd like to thank the Fiocruz Institute. In South Africa, I'd like to thank the WITS Reproductive Health and HIV Institute. And in India, it was the Population Council. And finally, in Ibadan, Nigeria, the Center for Population and Reproductive Health at the University College Hospital. So thank you very much.